Welcome, everybody. This is Hugh Massie, the CEO and founder of DNA Behavior, and I'm delighted to be hosting another one of our Behavioral Economics Today podcasts. And today I have with me Akinyi, Odera, and Ariam Hailemariam from the ThinkPlace group based in Africa. And, they've been doing some wonderful work in relation to data. And, one of the big areas I've been trying to bring out in this podcast is the practical applications of behavioral science, where psychology and economics meet. And the key thing has now become data. And Akinyi and Ariam are at the center of that, and they've done some fantastic work. And this was put across in their paper called the Integrated Ideation Model for data use culture. So they've really focused on the use of data in the healthcare scenario in Ethiopia. But I believe the work they've done has got universal application, and the principles could be applied in many other industries. In the industries I was thinking of, these two have got a whole ton more where they can see the applications for this. So welcome, Akinyi and Ariam. And maybe just before we get started, just tell us a little bit about yourselves and your passion, your sort of life path to behavioral science and your passion for the work that you're doing. And Akinyi, why don't you start? Yeah.
Yes. Thank you so much, Hugh, and thank you, Ariam, as well, for making time for this call. So my name, of course, is Akinyi Odera, and I've been at ThinkPlace for about 8 years now. A lot of my work has been in the development sector and predominantly in the public health system space. What I do is I try to understand human behavior, and especially the social and psychological aspects of human behavior. The intention is to, once we get a concrete understanding of this, is to try and understand what solutions make space. And so because we work in the development sector, a lot of my work has been around designing, using human-centered design approaches, solutions to issues like climate change, like education. I mentioned public health space. So I've worked in Kenya. Right now, I'm working predominantly in Ethiopia. I've also worked in a few other countries in sub-Saharan Africa. And I'm excited to be in this podcast today. I'm looking forward to share not just about data, but historic experience about design in Africa. Thank you so much.
Okay, Ariam, why don't you share a little bit?
Thank you so much. I'm really glad to be here with you too, Hugh and Akinyi. So my name is Ariam Hailemariam. I have been working as a behavioral science expert since I graduated from Addis Ababa University, Ethiopia. Since then, I have been applying behavioral science and human-centered design through different projects, especially in the context of social and health contexts. So currently I'm working around how to bridge the gap between intention and action, especially people intend to do something, but they fail to do it at the end of the day. So I'm applying this behavioral science concept in terms of understanding human barriers, especially the human element, to bridge the gap between intention and action. So I'm currently practicing those behavioral science and human-centered design concepts. So through this data use behavior. So this is a little bit about me. Thank you very much, Hugh, for bringing me here.
No, that's a pleasure, Ariam. And, again, thank you to both of you. And perhaps if we get to the core of what's driven the article that you wrote for the Behavioral Economics Guide, around data and data culture inside organizations, and you've attacked it in the healthcare industry in Ethiopia. So maybe if you want to, Akinyi, maybe you start just address what really is the fundamental problem that then needed a behavioral intervention.
Mm-hmm. Yeah, good question. So we started this work around 2022. And so when we began, what we wanted to do was to really understand, and this is together with the Ministry of Health in Ethiopia, and it's within a consortium. So ThinkPlace works closely with other organizations within the Data Use Partnership Project in Ethiopia. And so what we noticed was there were a lot of challenges as relates to data quality and data use. So a lot of health information systems practitioners will be familiar with the terminologies such as routine health information systems. So this is basically the system that allows health workers to report patient information, because every time you go to a health facility, the doctor will ask you what's your name, what's your age, what are your symptoms. And then in our case in Ethiopia, this is recorded on registration books, which are offline. And at some point, this data will be transferred to online platforms like the district health information systems. And so the challenge that had been there for quite a long time is that a lot of this data seems to be inaccurate. A lot of times it's incomplete. It's also untimely. So there's a system whereby data needs to be recorded on a daily basis, then it should be tallied almost on a weekly basis, then it should be reported towards the end of the month. So what we noticed that these dates were actually not complied to by most health workers. If you look at the health records, the patient information that exists in the registration book, there's a lot of gaps.
So maybe Ariam, if you answer this part of the question, what are some of the motivations or lack of motivations for the health workers, say in a hospital or in a clinic, for not recording the data properly? You know, what's been the barrier?
Thank you, Hugh. So that's a very important question. So as Akinyi has outlined, the health information system is especially the major attention from the government side of Ethiopia, especially. It's also mentioned at the health sector transformation plan, but especially the behavioral part is missing, and we have tried to identify the predominant behavioral drivers, especially in terms of applying this integrated ideation model, since it has guided us throughout the define and design phase of the project. We have identified the behavioral drivers. So one of these behavioral driver is low self-efficacy and cognitive overload, because staffs feel overwhelmed by too many indicators. They are also overwhelmed by priority tasks by giving services. Sometimes they fail to make this data-related works a default or a routine system or a routine task. So this data work is often out of focus. It competes with patient care, as I said, and it also gets deprioritized. It is seen as a secondary task for themselves. So people prefer some offline tools because they make performance visible, while digital tools are also often perceived as too complex. There is also a digital health information system for the district level where we implement our prototypes, but people fail to perceive these digital tools as if they are very complex. Especially we have categorized these behavioral barriers in 3 ways: the cognitive, social, and emotional factors. Especially the emotional factors, also the lack of instant gratification out of data-related behavior was also affected. It also plays as a primary role in terms of less adoption of data use behavior. So many don't see the impact of their data or receive feedback, so the effort feels detached from results, while their data or they receive some feedbacks, they really feel like they don't see the impact of data, so there is less relatability. So there is also less social responsibility amongst the team. There is no clear diffusion of responsibility, so meaning there is no clear demarcation for data related roles among the personas in the data cycle, which causes overlap of tasks at times, and it also causes weak shared ownership. So our personas in the data cycle is the service providers, the health information technicians, the performance review team members, and also the facility leaders. So there is an overlap of tasks. So staffs also feel less supported related to this data use behavior. So at the decision-making level also, especially the performance team members, there is futility and limited feedback meetings happen. So there is also like social expectation that influence the individual decision making. We have seen low self-efficacy, a sense of futility, and also when health workers feel unable to do something about the challenge they encounter, they feel like deprioritizing the data-related task. So these are some of the predominant behavioral drivers that we have identified during the define phase of the project.
Yeah, because when I read the article, I was seeing very clearly the connection between the cognitive, barriers, but also, time, people feeling overwhelmed in their work, that this is an extra thing they have to do, and sort of a mental barrier of, why should I do this if the data isn't actually ever going to be used, and I can't use it to help people get better. That's sort of what I saw as probably the big problem that you were bringing out in there, that it's not just about getting people to fill out the forms, but actually the leadership needs to put structures in place so that people can actually use the results of all of that data being gathered. Otherwise, it's futile. Have I got that sort of understanding right?
Absolutely. I think
Yeah.
especially this bit about the cognitive aspects really came out strong. And throughout our research, even through because we kind of started this research with an immersive exercise, or we went into prototyping and trying to test out different types of digital and offline solutions. And so there was a big sense of cognitive load, because you'll notice when you walk into a health facility, it depends on where you go also, because Ethiopia has about 13 regions at the moment. There usually will be a pastoralist kind of region, then an agrarian region, and mostly farming, and then urban context, like Addis Ababa is a fully urban, and Dawa is also a fully urban. So when you walk into a health facility in an urban area, there will be very many patients. The patient load is pretty high. And because it's a classic low resource context, the number of patients versus the number of health workers will usually not match. And so there's also challenges to do with a skill, kind of a capacity level. There are kind of like a training that is needed in health informatics that health workers will usually need to have. Some people will have it, other people will not have it, and especially the data clerks will usually not have it. So when you immediately present information that's to do with analytics, it becomes a little bit of a load for them, combined with the aspect that they're managing too many tasks that are related to health service provision is also a factor. So we saw that at play. And a lot of our work has been trying to make things simpler, make things more enjoyable. And when I say things, this is specifically to do with the kind of data, the way they record data, the way they pull data from the digital systems, and the way they use that data to generate insights to make decisions. So we needed to make that a lot more simpler and a lot more enjoyable, just to also manage the cognitive load that they currently experience.
And how much in here is technology an issue as well? Because I know that in Africa, I've been doing some work with a team that is helping schools out and getting to information just to teach the kids, getting access to the classes, the curriculums. And we're in an internet world. And I was reading in your article as well that, well, the same technology issues are potentially a barrier if the internet, and you've got to do this at home or in a facility that's not served well enough with broadband or satellite.
Mm-hmm.
It's also a problem.
Absolutely. Infrastructure is probably what we would call a foundational problem. And Ariam will go a bit more into this infrastructural challenge. She worked in a lot more urban facilities. I've worked a bit in the pastoralist facilities. And so when you go to a region like Afar, and Afar is towards the north of Ethiopia, and so here you will find mobile communities. The kind of challenges are related to, because we're talking about a mobile community, you will usually find challenges related to follow-up health service provision from a health service provision perspective. Probably when a pregnant woman starts antenatal care, she will come for the second one, maybe the third one. She missed the first one. She will do only 2 of them. She will not come back for the 4th one. So in that sense, you see those types of challenges from a data quality perspective. Then you see those reflecting in the kinds of like patient cards that they use to register this pregnant woman, for example. You'll see maybe because she was in this area last month, when she moves to the next area, she doesn't have that patient card. The system is also not interconnected. So if she might have like a number, a serial number that she presents, that will not be available. So infrastructure affects data quality in that sense. But even from an individual perspective, what we also saw, while it did seem that smartphone penetration wasn't a big deal, there were a lot of health workers who could access smartphones. It could be a shared phone in some cases. Yeah, but then you would need to install some kind of hotspot. So maybe the network is weak, so they have to move with this shared phone to a certain area where they can all pull their data. And so there were challenges that were immediately affecting the digital solutions, and we needed to build momentum, the perceived value for data, even before we position the digital solutions, which was really interesting. People really needed to feel like they are missing out on something for them to make an extra effort to go find it.
Creating the motivation to go and deal with the infrastructure issue rather than just making it an excuse. And Ariam, is there anything else you wanted to that? Because Akinyi was saying, alluded to the fact you had more insight on the infrastructure issues.
Yeah, yeah. So especially in Addis, I was testing the different testing sprints in Addis, and in Addis, where the capital city of Ethiopia, there is more of like different projects are implemented at the district health center levels. So I can say the adoption of the digital prototypes was high because they have access to digital like tools, especially they have like desktops at the health facility level. They have desktops. They have also their smartphone at their hand. So I can say the adoption of the digital prototype was high, but in terms of especially the data use behavior, it was still compromised. So the data quality was also better than the other regions. When we compare, we have also done a baseline assessment, and when we compare the urban and the rural context, the more of the data quality behaviors are like good in terms of accuracy, timeliness, data accuracy and timeliness and completeness. But the data use, like using those quality data in terms of applying those data to like inform decisions or to inform planning was still limited. So people were like, people didn't see the value of data, and also people have like less access to ownership, salience, and motivation. So people are also less motivated, especially in the urban context, to use these digital tools. So there was limited motivation, and also there was like this salience, especially the visibility of seeing the impact of data was limited. So I can say it has really contributed to the less data use behavior when we compare it to the regional contexts. So this was also one of the inspiration point. Actually, we will talk about this later, but this was also one of the inspiration point to advance our digital prototypes like EYTA. So this is just the main difference.
So you've made the problem part of the solution, which we can get to in a minute. But maybe so we don't jump a step is just to talk about your IIM model, the Integrated Ideation Model, that you built. It's got three key parts to it. And maybe we just explain that a little bit, and then we can get to the motivational solutions that you had.
Yeah.
So, Akinyi, do you want to start on that?
Yeah, absolutely. So the integrated ideation model for data use culture. So we're just going to call it the integrated ideation model for now. And so the inspiration behind it, basically the core of the model is the PRISM framework. So PRISM stands for Performance, Routine Information Systems Management. And so this PRISM model, basically what it says is that for you to manage your health information systems properly, you need to look at the organizational aspect, the technical aspect, and then the behavioral aspect, right? So that had been ongoing for many years, for quite a while, and especially tested in Ethiopia for probably 10 years before we started our work. And so a lot of focus was put on the organizational and the technical factors. When we did our desktop research, we were looking for behavioral solutions or behavioral components. When you look at the PRISM framework, there was not a lot. We saw a lot of technical solutions, and we talk about technical, it's both from a skills level. So there were a lot of interventions that tried to improve the skill level of the health workers. And then to improve the infrastructure, like we've talked about, access to these computers, to the reporting formats, and this is the registration books and the monthly reporting formats. So that was the predominant type of solutions. So what we noticed was, again, there was this attention, there was a missing piece, the behavioral part was missing. And so we saw a lot of attention towards what are the behavioral factors. We've provided skill, we've provided resources, but still we don't see this translating to data quality and to data use in terms of accuracy, timeliness of data. And so there was a bit of attention to, we need to explore this a bit more. And so what IMDC comes to do is to deep dive into the behavioral components. So we looked at just from our research, our primary research, and the baseline that Ariam also talked about, when we didn't start with the integrated ideation model at the start. We kind of wanted to get a sense of what are the behavioral influences at play. And so we saw, yes, the existence of capacity as a factor, the existence of the opportunity, the resources to actually record data, then finally the motivation to do that. And so we started exploring how could we go deep into the motivation component. So that forms the COMBI framework, which is part of the integrated ideation model. So we deep dived into the motivation factors. And to do that, we brought in the ideation theory. So the ideation theory, again, now guides us to explore the motivation factor a bit more comprehensively by looking at the social, the cognitive, and the emotional aspects. And so from a social perspective, we saw the presence of the need for a teaming type of intervention. Social support was really important, like Ariam was talking about earlier. So where there was no sense of shared responsibility, data quality or data reporting tasks were only seen as the responsibility of data owners, this would be a problem, right? So we worked on the social from that aspect. And then from an emotional aspect, we started thinking about, okay, how do we make it a lot more enjoyable and a lot more meaningful for health workers to perform these tasks. So that is where the emotional aspects came into play, which is a factor of the ideation theory. And then, so there's a cognitive, the emotional, and the social aspects. The cognitive I talked about earlier, making data quality a lot more simpler to use and a lot more, especially for health workers who are not fully trained on health informatics and have like a wide array of responsibilities on a day-to-day basis. And so this is how the integrated ideation model came into play. We used the PRISM framework as a foundation. Then we deep dived into the behavioral components using COMBI. and then deep dived even further into the motivational components using the cognitive, social, and emotional aspects.
Yeah, because the COM-B was really, I think, is probably the big one from a behavioral perspective, and you can't get people to do things if they can't do it, right? So you have to have the infrastructure there, and then it becomes the motivation. And I think what I was hearing there is that part of it was to create a team environment for people, and maybe Ariam, you can answer this part that plays into the STARS model that you built to motivate people, and maybe you would like to talk about that.
Yeah. I want to quote Dale Carnegie's thought here. He once said, when dealing with people, remember you're not dealing with creatures of logic, but creatures of emotion. So basically, one of the blind spots of many theories is that they often miss the emotional dimension of human behavior. So I believe that there is nothing more practical than a good theory or model. So the integrated ideation model has really helped us in terms of unpacking the need for social, emotional, and instrumental aspects, especially in terms of creating or forming a social norm or changing a social norm within the health facility. So by doing so, it has also guided us to refine our interventions across the different testing sprints. So we had been doing a repeated iteration throughout our mid-fidelity, high-fidelity testing sprints. So we have been using this integrated ideation model as our guiding framework, since it encompasses the cognitive, social, and emotional aspects or dimensions of the human behavior, as Akinyi mentioned. So guided by this model, we have been flexible and adaptive to the changing realities at the health centers and the dynamics of the end users, of course. So this integrated ideation model has allowed us to better understand how the social, emotional, and cognitive aspect influence human behavior, and even how they interplay with each other. So this has really helped us in terms of understanding the human behavior or the end user's behavior, or in terms of like designing the conceptualizing, operationalizing our interventions at the health facilities.
So Ariam, just going further with that though, the STARS model, if I understand it, is about appealing to people's sort of intrinsic motivation more than the financial motivations, because I think you guys figured out if we give people financial rewards, it's going to cost a lot of money, and then the day it's removed, there'll be a loss aversion, something's being taken away. So really, you had to appeal to the intrinsic side of making people look good in the teams. Is that right? So people felt good about their job, they might get promoted. It sort of played into how they're evaluated. Is that, maybe if you one of you talk a little bit more about just the STARS model and what the thinking behind that.
Maybe especially there is also a prototype where we tested so Akinyi, she might be better suited for this.
Okay, that's all right.
Yes. I'm super excited about this. I've been crazy about motivation and intrinsic, extrinsic aspects of it. Yeah, so it's been really interesting prototyping the DataStars Spotlight. So basically, what the DataStar Spotlight tries to do is to instill. So basically, what we want to do, you're right, Hugh, we want to try and make sure that there's less attention to extrinsic motivation and more attention to intrinsic motivation. And so when we started DataStars, what we wanted to understand is how to make data reporting as consequential as health service provision, right? So we kept feeling like a health worker will pay a lot of attention to probably managing a pregnant woman and helping her to deliver, and because they feel that if they don't do that, it has bigger consequences as comparing to failing to report the data of the line, the queue of patients that's still waiting. So we saw that this is a little bit an equal. And then every time we mentioned recognition, usually it was linked to tangible rewards. And in some cases, in a lot of cases, actually monetary benefits. And this is common practice because we've seen a lot of previous programs use monetary benefits as kind of the reward for participating in a program. If you go for a training, usually you'll get paid per diem. If you are engaged and you spend your time for about 3-4 hours, you get compensated for that. So there's already a lot of exposure to monetary benefits. And I believe that this is part of the challenges we are encountering over and over again every time we talk about recognition. So what we wanted to do is to delink our concept of motivation from money and try to talk about more sustainable recognition strategies. So during one of our testing sprints, what we had was a health worker who was talking about, like whether or not you report data, nobody will notice. There's nobody who will give you a thumbs up, will tell you good job, who will give you feedback about whether you did it correctly or not. So it has no consequence. No one notices. And we thought that was really powerful, right? And so we also kind of noticed that there was no explicit feedback system. So that when health workers report their data, they do it, then they hand over their reports, maybe to the data clerk, who will hand it over to the district health bureau, then to the regional health bureau. So their work keeps moving up the ladder and it doesn't come back. They don't see this impact of data, So it gets lost somewhere up the ladder. And so we tried to use DataStars Spotlight on a dual function. So one, we tried to make sure that the leaders in the health facilities themselves, because they're present on a day-to-day basis, they need to be a bit more intentional and consistent in managing data tasks. They need to be able to recognize when somebody has done their recording on a daily basis, they're tallying on a weekly basis, and tell them, good job, you can go home now. Right? So that's as simple as the informal recognition part that we wanted. And then over time, we noticed that this needs to go beyond thumbs up, good job. It needs to evolve into, maybe a social recognition, because usually when you walk into a health facility, you'll see there's a routine. Once a week, there will be a morning session where they talk about the different challenges that they encounter with patients. And so this was largely the only forum where health workers came to sit together. And so we explored, is there an opportunity to socially recognize health workers who actually do their job and make sure that this is done by the facility head, because he's the authority in that sense. So we wanted to play around with authority bias. And so we were successful to some level. We saw that in health facilities where there was less structure, there was less leadership presence, DataStars Spotlight took root very well. The adoption was strong. And this is as compared to facilities where there was full structure, where they were already into the habit of reporting data on a daily basis, telling on a weekly basis. They didn't want a thumbs up. They wanted a punishment. So we kind of realize there's a difference over here. We have to understand what's the context of the health facility, where is the habit, where's the maturity level at, and therefore how do we best apply the DataStars Spotlight. And so we try to encourage the health facility heads to be adaptive. They could try to do a self-assessment. And this also starts with a self-assessment of the health center. And so we created a sense of scenarios. And so these scenarios are based on what's the leadership style, what's the data management practice that's in place, what the social support look like. Based on those, the health facility head will know if to apply a thumbs up or if to apply a certificate of recognition or in some cases, even a sentimental kind of gift. In some cases, like in Addis Ababa where Ariam worked, there was a bit of use of jewelries, but we saw social recognition as strong. Anything that supports professional development also as very strong, then things with sentimental value.
So it's very easy for certain types of leaders, I think, just personality-wise, to go to the punishment side. Well, they didn't do it. I'm paying them, therefore we'll punish you. But while people might do it, they might also leave and not feel very gratified with what they've done. And I think what you've done is gone to the positive side to make people feel good about themselves when in their mind they're doing something that's an extra and they haven't totally seen the value yet.
Mhm.
And have you thought about, in some of the testing, looking at the personality of the healthcare workers and seeing which styles of people respond better to believe in data, for example, and those that might respond to these influence type rewards where they look good in a team? Have you done anything with that at all in looking at personality?
Sorry, yeah. Especially, are we talking about the recognition aspect?
Yeah, I think just understanding that you're communicating a message to the healthcare worker that we want you to fill out these, forms, whether it's by paper or digitally. We want compliance with data gathering, but we're also going to reward you. And have you looked at the types of people from a personality perspective that are going to respond to that better than others?
Yes, definitely, Hugh. I get your point. So we also had the prototype champions where we try to select some of the health professionals that were performing well, especially in terms of even understanding our prototypes and also in terms of performing well around data tasks. So one of the recognition aspect is what we noted, especially around the personality trait, is when we selected those prototype champions, it was also one of the sustaining strategy for us. But for themselves, for the prototype champions, it was an intrinsic motivation towards accomplishing their data-related tasks. They feel like to do more about that data-related task they have been given. And also a kind of social norm was also being formed in the health facilities in terms of people observe those prototype champions, and they were very curious in terms of why we selected those prototype champions. And then it was also one of the communication, or it was also one of the discussion point amongst the staff members. So I can say it has really played around the intrinsic motivation rather than the extrinsic motivation. So it's just to add this one here.
And I think, I think it's good that what we've brought out here is that people don't just respond to money. It's that the intrinsic rewards are good. I think it just proves this point. Again, we've done a lot of work in the hiring area, just in recruiting people and managing employees and knowing that what they get paid isn't the only reason that they come to work. Getting paid enough is important. But if they're working in a good environment and they're feeling good about themselves and learning and there's some flexibility, all those type. There's a whole lot of different training. There's a whole lot of different rewards that you can provide. But so that just to move along, because I think there's a second key piece of the whole program that that you've brought into play here, being the EYTA Telegram model, which I think, if I understand it correctly, I would call it in the United States a chatbot, but it's an online app where the health workers can interact with it to in a way see the results of their inputs so that they can then deliver better healthcare service. So maybe if you talk about that part, because I think this is part of the gratification as well, is that, well, I've fed this data in, now it can be used by me and others to get a better healthcare result.
Thank you, Hugh. Maybe I can start something about this. So especially I want to start from the inspiration and the value proposition around this prototype, the digital prototype. As you said, it's a chatbot. So the inspiration behind EYTA is a local name. So the inspiration behind EYTA is like it has born from our simple observation. So many health workers record data every day, but they rarely see or use it. So that was our inspiration to come up with this concept. So these frontline workers, especially, they had like less visibility into their own performance, limited opportunities to compare progress across the different departments, and also almost no real-time access to data analytics. Especially this data analytics issue or task is given for the higher level managers or the facility leaders, not for the service providers. So we were like trying to bridge this gap in terms of introducing this prototype. So the value proposition of EYTA was like enabling easy access to information for service delivery and planning in terms of improving visibility of data and its impact as to improve the perceived value of data. So EYTA is a digital tool, so it's designed to make data accessible, understandable, and actionable for everyone. So it also enables the health workers to view real-time reported data, visualize trends in service delivery. So through direct integration with the national system, which is DHIS2, this chatbot gives users immediate access to the same data used by the decision makers. So it's more of mobile friendly, it's designed in local language, and also it sends them notification and alerts on the updates and the deadlines in terms of data related tasks. So this intervention especially targeted access, simplicity in terms of reducing cognitive load, convenience, and habit formation. Salience as a tool of improving this data use related behavior. It also encouraged the health workers to check and discuss data more often. So it had contributed in terms of forming a social responsibility. So especially the both simplicity and convenience has significantly reduced the cognitive load. People could access key indicators right from their Telegram or WhatsApp channels. So we have also witnessed there was habit formation for the staff, especially when they use EYTA routinely, they start to be dependent on the chatbot. So it has significantly affected their data use behavior. So ultimately, we have seen EYTA work because it has aligned with their intrinsic drivers, especially giving people a sense of competence, ownership, and visibility of their daily work. So anyone can just go to the chatbot and refer to their data, so they can see what they have done, what service they have given. And also for the managerial level, it has also been used as a planning tool, decision-making tool. So based on data, they started to make decisions and planning. So that's what we have witnessed firsthand from the EYTA chatbot.
Yeah,
Mhm.
I think it's very good, and you've been extremely innovative, and it's made the use of the data very tangible for all the healthcare workers. And just to switch gears a little bit, and maybe Akinyi, you can address this, the role of leadership in a major data project like this, because I think that that the leaders need to be completely bought in and understand and appreciate the investment that's involved, but what the outcome is too, potential
Yeah.
outcome to their organization.
Yeah, absolutely. So leadership is, aside from increasing the perceived value of data, we've seen it's one of the biggest drivers of behavior. We've seen that if a leader is intentional, is consistent, is present and hands-on in the health facility, this results to better outcomes for data quality and use as compared to when the leader is absent, is kind of not interested, is not recognizing people, is not communicating data-led decisions, right? And so what we've tried to do is to build, not build the capacity, but kind of interest the health facility leaders with how can they simply and on a day-to-day basis practice the desired leadership behaviors. So we called out these core behaviors in one of our prototypes. We called it the leadership playbook. We are now testing it in 3 regions. And so when you look at the leadership playbook, what we are trying to do with it is to encourage leaders to practice how to set and communicate a vision. So in a simple manner, then how to manage data practices, and that stimulates intentionality and consistency. Then how to advocate among higher levels. So because there's a structured health system in Ethiopia. So this management, advocacy, proactive advocacy, and setting and communication a vision is what we really wanted to push in a very simple format. So when we introduce the leadership playbook, we want again to encourage leaders to kind of self-assess, think about what's your leadership approach, because we discover that we can't apply a blanket approach in all the health facilities. And also because leadership is influenced by various systemic factors. There's a political element, there's a cultural element, there's a support, again, within the health facility that determines if a leader will be present or not. And so we decided to ask them to self-assess what's possible for you as a leader to do. And then so we showed them how to be more intentional, like how do you create a vision, yes, but then how do you rally people around it? And we used kind of a gamification prototype. We called it a change challenge. So in a change challenge, there will be a quarterly assessment of what's the status of the health facility in terms of data quality and use. Are they 50%? Are they 10%? So if the goal is to get to 50% in the next quarter, they come up with that as a challenge. So that becomes the vision, and then that becomes the rallying call for the health facility. So it was also very practical because this is a system that they're already exposed to, these assessments. They may practice it almost every quarter, sometimes they don't, but we wanted that to be a habit that a leader practices. And we wanted them to also talk about rewarding people. And when we were talking about rewarding people, we wanted them to do it in a self-sustainable manner. So look at your budgets as a health facility. Are you able to accommodate things like certificates if there must be an extrinsic aspect? If there's no extrinsic aspect, let's capitalize on the informal behaviors, on the informal leadership behaviors, whereby you recognize, you create meaning, you create purpose. And we make sure that we balance this with extrinsic aspects because we saw that was still important. We cannot totally throw it away. Then we also encouraged the leaders to, when we were talking about advocacy, and especially among higher leaderships, is we saw if the leaders are more in tuned, they have good relationships, they have the confidence to approach the district health bureau, then there's a higher likelihood that they will try to mobilize for resources. Simple resources like, I may call it simple, that might be subjective, but then the ability to print a reporting format, take it to a health facility is something that we were able to see. If we communicated, you need to do this tomorrow, they were able to do it. So just sustaining that practice, mobilizing resources when they did not have them was something that we wanted the leaders to be more comfortable to do. And so also advocacy in the sense that they can ask for budgets to be reallocated, because when you walk into a health facility, you also need to approach during the planning meetings. Where's the confidence level when you're talking about, let's not prioritize a certain budget category, let's take it because it's probably 10% of the total budget, let's take it to printing of these resources. So the ability to push back, to communicate with confidence, to speak up during a performance management meeting, these aspects really supported the leadership behaviors that we wanted. Yeah, I got the sense when we were talking about personalities earlier that sometimes a leader's behavior will also be influenced by the social support within the health facility, right? And so in some health facilities, you'll notice there are there are people who've been there for 30 years, 40 years, probably 20 years. So we call them chronics. They understand the systems. They are very, they can argue. There will be a little bit of back and forth. It will not be very comfortable for a new leader to do that. And so comparing that with a facility that's probably new, has younger health workers, they're more interested in professional development, in moving maybe to the next urban center. They don't want to stay there for long. The social support and hence the leadership behavior also varies depending on those factors. So I found that really interesting.
Yeah, and I think it's the motivation for the leadership as well. What's their motivation to make these changes? Because really what we've talked about today is making a fundamental change, a transformational change to how healthcare is delivered. And and there is organizational transformation and gone on major league, and it would lead to better healthcare outcomes, which should be a reward for someone, and better financial management in the end of the healthcare system. So there's a lot at stake, and if we really sum it up, engaging the leaders is, vital. But I think looking at this through organizational change and this kind of transformation through data, it's very powerful. And I think this is what we're really bringing out here, is that if we have the right data culture, look at the organizational transformation and the value that gets created, that can come. And my point would be, or question, just to wrap up, just a little perspective from each of you, just to finish off our conversation, because we could go on all day, is what other industries do you see this happening in, where we can take go and change the data culture and essentially change the culture of the whole organization?
Yeah, good question. So we are very excited about how we could apply these insights in the tech industry. And I feel that we're in the digital transformation age, right? So a lot of products, a lot of services are today enabled by AI, especially as compared to probably 5-6 years ago. And so we also know that the foundation of any AI system is only as good as the data that it's trained on, right? And we saw this first. We tried to develop and to test an AI-enabled prototype in some of our regions where the infrastructure is relatively stable. And so the level of uptake, the perceived usefulness, perceived reliability of these types of solutions was really dependent on if the health workers see that there's less outdated data. There's a sense of comparability. I can compare data from a health facility with the next facility. So the more they encountered inaccuracies, irrelevancies, the more they deprioritize the AI-enabled solutions. Even EYTA encountered this challenge to some level. And so we thought about, okay, moving beyond the health information systems, if you want to develop a product or a service that's AI enabled, what do you need to think about as a practitioner who's training this AI system? And so we are looking at still examining the social, the cognitive, the emotional enablers. What are the social norms that the person who's training is exposed to? Because then we can also try to manage the biases that usually we usually see within AI systems. So just being able to closely examine what's the teaming aspect within the organization that the health worker works, what's the culture that they are sitting in, because we saw this also at play in the types of data we collected we call it Dr. Buddy Telegram bot. Does the organization provide the skills? Do they provide the resources that they need? Because also this plays into the type of data that's also produced. In the climate data space, we feel that it's probably not very strong right now, but we see it coming. It's an emerging area in Africa right now. We are probably talking about setting up the regulations that the private sectors would be required to abide by when they're reporting data. We are also setting up the formats that they would use, the spaces that they would use to engage decision makers and the communities. And so it may not be an issue now, but we get the sense that it might be an issue in a few more years to come, especially as the regulations start to dictate that private sectors need to avail their data. Then at that point, thinking not just about the regulations, but also the human factors. Who are the humans who are reporting the data? Is there potential for data falsification? Does the system enable or disable them, or kind of enable them to report the right data? I think those are important things to think about right now.
Yeah. And thank you, Akinyi. And Ariam, have you anything else you'd like to add?
Thank you so much, Hugh. Maybe just to add on what Akinyi have said, we have seen early results from our intervention testing in terms of improving the knowledge, attitude, and practice part. But still, there is an intention to action gap, especially in terms of the leadership agency, especially in terms of resources, access to resources, and the purchase of different data-related materials. So still there is an improvement of the knowledge, attitude, and practice part. Even though we have seen the improvement, there is still an intention to action gap in terms of leadership agency, for example, in the providing the resources, access to the different resources like registration books, log books to the health facility and health bureaus. So we have seen that even though we have improved the knowledge and the understanding of data-related roles in practice, reduced externalization of data tasks related to for the service providers especially, and also improved the ownership of data. Like we have also witnessed simple innovations have been improved data recording, the visual reminders and the nudges have been very important, but still there is an intention action gap in terms of this leadership agency resource. Depending on the context, there is also resource limitation. So this is just to mention while others think about adopting this model or our learning, I can say. Yeah, this is just to supplement.
We might just wrap up there. So thank you, Ariam. We might just wrap up here just because of time, but I think this has been a wonderful conversation, and we've really brought out some massive issues and constructive solutions that I certainly hope that not only the healthcare industry globally learns from, but also many other industries, because I do see data as being the future of behavioral intelligence, and there's so much more value that can be created for organizations if they're behaviorally intelligent, but built with the right data. So thank you. So is there just a one word or a quick phrase to close off that you would like to share?
Yeah, I have one. So I think over communication usually is a principle that I would encourage any leader who's working on data to focus on. I think when we don't communicate the impact of data, then it loses the health workers, the team that's working with you loses the perceived value. The perceived value basically decreases. So over communication for me stands.
Communication's everything. And Ariam?
Yeah, just to say one thing only, we need to create a space like innovation labs within institutions, and we also need to build a design mindset across teams, because this design thinking and the behavioral thinking has a lot of implication in terms of building data use culture, not only limited to data use culture, but beyond shaping human behavior. It has really contributed a lot. So institutionalizing innovation labs and design mindsets across teams is very important.
Yeah, because I've been writing about that just recently around having an enterprise data warehouse, and I think that could sit side by side with the innovation that all the
Mhm.
organizational data has got to be centralized and gathered properly, and the right data. So thank you, Akinyi and Ariam, for a wonderful conversation, very deep, and I really appreciate having this opportunity with you.
Thank you so much, Hugh. It's a pleasure to be with you too.